Morning, morning everyone. Hope you're all well. Had a good weekend. Looks as if everything is working okay. I'll just pop a message in the chat. Just make sure that's working. That's looking good. Cool. We'll get going. If you got any questions as we go along, then please feel free to add them into the chat. Had a really good day Saturday. I think we mentioned last week that we had visit to the labs at Kiel on Saturday, just gone. So it was good to see some Learn Anatomy Online faces there. That was really good. And we had a really good session. Really good clinician there again. So that was it was good. So, but our next one is in London in July. I think it's July the 3rd. We've got a bit of a break, but before the next one, so nice and sunny in London for the next trip. So if you fancy joining us for that one, then you can go to clinicalanatomy.education and then join us there. Cool. Right, let's get you guys going. So this is where we were last time. So we had just want to recap the compartment of the thigh. And again, I mean, every time we were talking about this on Saturday, every time we go to the labs, even though I've been going for like 20 years, you still learn new stuff, which is really cool. Because people have got different specialities that they've been focusing on throughout their kind of anatomy career. And the people that we've got on the courses as well are different from different backgrounds. So always picking up new stuff. And good morning. Good morning. We have got some people in this morning. Good morning, morning, Stevie. Good to see you there. So we and it was really good because we were talking about this. We have been over the last few weeks. So these intermuscular septums, which divide the compartments of the thigh, and we actually saw that for real. So have a look at the IT band. So this area here, the iliotibial band. And it's not, as we've seen before, it's not a band. It's continuous all the way around the leg. But this bit here is thickened. But also, there are sections that attach to the femur directly. Okay, so they compartmentalize these groups of muscles and kind of wrap around them. And there was a really good demo of that because we had a dissected iliotibial band that you could put your hand under, and then you try to get around to the back of the thigh, and you can't get there. And the reason why you can't get there, you can't move around underneath that fascia, is because it's connected to the femur. So it was a really good demo of the compartments of the thigh, which is what we've been talking about. So that's good. Good morning, Penny. Good morning, Tris. Good to have you in this morning. So so we've been looking at this anterior compartment. We've been looking at the medial compartment as well. So we looked at that last time. Had a look at the adductor magnus and the hiatus. So that will then lead us onto the blood vessels, which will be in a couple of weeks' time. So I'll pop a message in the group. But this is the last one for a while, so I'm not teaching in America until after the summer, but I am next week, so I won't be here again next week, unfortunately. So sorry about that, but give you a chance to catch up on things if you need to. I'll be here the week after to wrap up the knee. Okay, so just to let you guys know. And on that session we'll cover the blood supply. And whilst I'm away, I'll start prepping the lymphatic system, which I think Eleanor wanted to see. So we'll do a specific session on lymphatics after we've done the knee. Okay, so we'll sort that one out. So just a quick recap of the compartment. So we've done this one. We're going to do this one next. So this is your posterior compartment, and we've got three muscles, but four really, in the posterior compartment. So we've got semimembranosus, semitendinosus. Then you've got your biceps femoris, which is split into two heads. So you've got your long head and the short head just there. So those are the next ones we're going to have a look at. We'll just do a quick recap of these. So we had a look at rectus femoris, the most superficial of the anterior thigh. Vastus lateralis, so big, vast. On the outside, lateral. Okay, so that's your vastus lateralis. The differences between this one, rectus femoris and vastus lateralis, is the rectus femoris crosses the hip. So it's a biaxial muscle, and do you call it diaxial? Biaxial? I think it's biaxial. Basically two joints. Okay, so you've got the attachment just above the hip, and then it merges into the quadriceps tendon, and then goes into the patella tendon, patella ligament, whatever you want to call it, and then into the tibial tuberosity just here. We talked a little bit about the differences between the tendons last week, and mentioned a chap called Pete Maliaris. So hopefully you guys managed to find him and see his stuff. He has updated his course. He's just launching a new one now, sending out loads of promo material. So it's all about tendon rehab, and he's really good. He's all the stuff that I base my kind of teaching on is he's written the papers. So he's really good, and a good presenter as well. So vastus lateralis doesn't cross the hip, but it crosses the knee. And then you've got vastus medialis on the inside, and then in between those two, so vastus lateralis outside, medialis inside, and then you've got intermedius in the middle, and that's covered. So over the top of this muscle, you'd have to peel back another layer because rectus femoris is over this one. Okay, so that's the kind of orientation of all of those muscles and the layers. We talked about articularis genus. Asked a question of the clinician on Saturday about this muscle, and there was a colleague that she was working with that is doing some research on this particular muscle, and that's the thing when you study kind of master's PhD level, you focus in on one specific thing. So when I did my clinical anatomy, I did 2 years purely on pec minor, and that was it. So I know that region of the shoulder quite well. And this lady is doing some research on articularis genus. Although the clinician that was there on Saturday had never seen it, it's because it's one of those that is kind of just ignored, really, when you're dissecting, and because you look at the gross musculature, unless you're doing a specific project. So that was quite interesting. So it does exist, definitely, just not seen that often on cadaveric specimens. So there we go. Sartorius as well. So we're having a look at that and the relationship between the femoral triangle and how it covers the over that adductor hiatus region. It forms like a roof over that. So we had a look at that last time. The medial compartment we looked at. So we looked at magnus. So, but obviously magnus means big. Adductor means it adducts its main role is an adduction of the thigh. Because of the orientation of these fibers, these ones just here, and the nerve supply of them, which we'll have a look at in a second, this particular part of magnus assists in extension of the hip as well. So that's why it's considered a fifth hamstring. Okay, so and we kind of introduced you to that last time. We looked at adductor longus. There was another load of adductor muscles that we haven't looked at yet, and that's because they relate more to the hip than they do to the knee. Okay, so we'll get to those when we get to the hip. So we looked at longus. We looked at gracilis as well, which is another one of your adductor muscles. Again, two joint muscle, so one that will often get injured with adductor strains, that kind of thing. So gracilis is a usual culprit, and especially around this area here, we've got three muscles that attach down here. The Sargent group, sartorius, gracilis, and semitendinosus. So this area can be quite tender. It's the Pezanserine area. We've mentioned that before as well. And there we are. So we are now at the posterior compartment. So posterior compartment, we're looking at the hamstring group. So if you remember that image, that cross section from before, so we had semimembranosus, semitendinosus, and then biceps femoris. So biceps means two heads. So we've got a short head and a long head. Okay, so those are those muscles there. So let's start having a look at the hamstring. So obviously, if you didn't know, they attach above the hip as well. They attach onto the your sitting bones, so your ischial tuberosity. So if you're not sure where they are, if you lift yourself up, put your hands underneath your bum and have a bit of a wiggle around, the bony bits that you can feel with your hands, those are your ischial tuberosities. So you know if someone sits on you on your leg with a bony bum, those are the bits that dig in. Okay, so that's your ischial tuberosities, which are here. Okay, so that's those bits up there. So this is one of the hamstring group, and the name tells you what kind of appearance the muscle has. So semimembranosus is half membrane. Okay, so it's quite flat, or it's fairly flat compared to the others, but there's a obviously muscle tissue within it, because it's contractile, but there's a lot of like what looks like a membrane. Okay, so it looks like a flat membrane, compared to tendinosis, semitendinosus, which means half tendon. Okay, so that looks slightly different. So membranosus is deep. Okay, so in terms of kind of manual therapy and palpation and things like that, you will only be able to feel the distal portion of membranosus, and that's because it's covered. Okay, it's covered by semitendinosus. So in terms of kind of identifying hamstring muscles and that kind of stuff, you'll struggle to say, "Yep, I'm on semimembranosus," because it's too deep, too much stuff kind of in the way, and also if we think about some of the other musculature that's around that area as well, you've got all your adductor group around that region, adductor magnus. So to be specific is really difficult without imaging. Okay, so we would know that there'd be a problem if you palpated something and you felt that there was a dip in the muscle or something like that, or a specific point that was painful. We would you obviously do your tests and test the hamstrings to see if they can contract them, but because there's other muscles that do that role, and because of the number of different sections in that area, all we would know is that there is something wrong with the posterior thigh. We could guess that it was a hamstring, but you'd need to have imaging to make sure. Okay, so again, that if you're thinking you're feeling things specifically, you're probably not. It's really difficult. It's difficult to do it when there's no skin. Okay, so when you're looking at a cadaveric specimen and you're kind of going through the hamstrings, you go, which one's that? And you have to track it back to work out which one's which. So imagine trying to do that with skin in the way as well. So this is your membranosus on the medial aspect. So we know that because there's your fibula. Okay, so that fibula is lateral. So ischial tuberosity, sit bones onto the medial condyle of the femur, of the tibia. Sorry. So tibia just here, and it attaches just up there. Okay. Let's do the other two, and then I'll show you some videos. So this is tendinosus. So it's half tendon. You can see it's got a really long tendon distally. Okay, not proximally, but it's distal, and this is the bit that you can feel. So this one's quite easy to feel. So it's on the inside of your back of your thigh. So if you have a feel on the back of your knee, put your foot down on the floor, and then imagine that you're scraping dog poo off your shoe, and you scrape your foot backwards, and on the inside, so just behind the crease of the knee, you'll feel a tendon immediately pop up. Okay, and it's really obvious. It's a real obvious tendinous structure. That is that. Okay, so that's a really easy one to feel. So I can feel that straight away, and I can track that tendon up probably to about around about here, where it then starts to merge into a muscle. Now the reason I can feel this one is because tendinosis is on top. Okay, so it's the most superficial of the medial hamstring, so you can feel that one quite easily. And the only way you can feel membranosis is by using tendinosis. So you do your dog poo scrape, have a feel of the tendinosis tendon, and then if you just move off of it and then tuck under it, that's where membranosis is. Okay, but you can only feel it in this region here. Okay, anything above that, it's too there's too much in the way. It is a big old bugger. Yeah, it's a chunky tendon, that one. Okay, it's a real good landmark for palpation. Okay, so if you want to work out where structures are in the knee, you can use tendinosis. And when you scan it, we call it the cherry on the cake, because in a certain view on ultrasound scans, you can see semimembranosis underneath. So imagine that semimembranosis muscle, because it's underneath. Tendinosis is on top, and tendinosis is a thick tendon, and membranosis is flat and quite chunky. And when you look at it kind of side on like that, that bit looks like the cherry, which is the semitendinosis, so cross section, and then underneath it is your semimembranosis muscle. So it's a really, really useful landmark to work out where structures are in the back of the knee. So you can track that tendon along. Obviously, I mean, I've palpated it on, well, so I have palpated it. I tried to palpate it on someone and it wasn't there. And it's because they'd snapped their tendon. Okay. So if you should be able to feel it, and it should be really obvious. And if there's, they've heard a snap, or they've got pain at the back of the leg and you can't feel that tendon, they may have ruptured it. Okay. So, and this particular person had. And then when you scan it, there was no cherry. So that was interesting. So we've got, that's your semitendinosis. This is on the inside as well. So this is the medial aspect of the thigh, and it attaches onto the front of the tibia into that pes anserine area. So along with gracilis and sartorius. Okay. Does exactly the same job as semimembranosis. It's like I say, it's the most superficial one. Hamstring strain, more likely semitendinosis. It's more likely biceps. That's the most commonly injured hamstring. Is biceps femoris. There must be some kind of biomechanical reason why, but it's usually biceps femoris that goes. Yeah, it's quite unusual actually. That's the only one I've ever seen where the semitendinosis tendon just wasn't there. Okay, so that was quite interesting. But this is why you kind of go through a structure with your clinical exam. So you do your active, your passive, active resisted, palpation, all that kind of stuff. Is to spot anything obvious, really. And you go, right, okay, next one on my list to check is semitendinosis tendon. And you're like, there's nothing there. That's a bit weird. So that's why we go through things systematically. So next one is biceps. So two heads femur. Yeah, biceps femoris. This one goes laterally and attaches onto the fibula. All right, so it attaches onto that fibula head. The short head of the biceps attaches onto the back of the femur, around about halfway up on the linea aspera. So just there, or linea aspera, whatever you want to call it. So here we go. So ischial tuberosity is long head, so that's up here. linea aspera and lateral supracondylar line, so that it attaches along a broad contact on the short head on the back of the femur just there. Okay. Now the one that the area that usually gets injured is here, and that's the musculotendinous junction, so the MTJ of the biceps femoris. That's usually the one that gets injured if you injure a hamstring. It could be, yeah. Is it because of the two heads? Yeah, possibly. Yeah. Obviously biarticular muscle as well, crossing two joints, but then the other two are as well. Maybe it's the forces going through the lateral aspect of the leg, especially with sprinting, that kind of thing. There must be some kind of biomechanical, morphological reason why. Cool. Yeah, so that's your biceps femoris. So two heads, femur. So long head attaches here, short head here, and then they both join together around here and then attach onto the fibula. Okay, so it's two into one, like kind of like a Y shape. Yeah, cool. Okay, let's have a look at those. I think it's this one. So this one is this is broadly all of the hamstrings. Okay, so and then we'll focus in on the knee on the second video. Okay, so let's just pause that a second. Okay, so this is the back of a right leg. There's the greater trochanter. So obviously all the skin's been removed, and you can see the muscles underneath. These is your sit bones region. You've got your gluteal muscles up here, and you can see the adductor muscles just here as well. Let's just pop those on. So there we go. So let's just go back a second, just so you can see the relationship. So there's the back of adductor magnus. Yeah, so we can see the adductor magnus. Yeah, that all looks like magnus. Is gracilis maybe there? Looks like it might be gracilis there as well. So you can see all of that structure at the back of the thigh, and then boom, there's your hamstrings on top. Yeah, so you can see the layers of that posterior region. So even though this is the posterior compartment and it's all separated by fascia, you can see how closely related the compartments are. So it's not like, oh yeah, there's a section there, there's a section there. They all kind of merge in together, but they're separated by these films of connective tissue. So hamstring group, so 4 muscles altogether: biceps laterally, semimembranosus, semitendinosus medially. And then that area there, we'll have a look at this in a bit more detail when we get to the knee specific video. But can you see that there's a bit of a diamond formation at the back of the knee? Yeah, so we've got the top part, or if I split it into 2 triangles, so we've got a triangle here. So there's the knee joint line there. So that top triangle is you've got your biceps femoris on one side, and then your semimembranosus, semitendinosus on the other. So as the hamstrings come down and they split and they join either medially or laterally, they form an opening at the back of the knee. And in that opening is your neurovascular bundle. So the nerves and the blood supply that go down the leg. And when we did the calf and we looked at the leg, that this is the bit that we finished on. Okay, so hopefully it's starting to put the levels together. So there's your biceps. There's semimembranosus, semitendinosus. So if we have a look at there, so there's membranosus there. So we can see that it's got it's quite a lot of it's a very flat muscle compared to tendinosus that you'll see in a second. So this is the image that you'll see in the trail guide to the body. So ischial tuberosity there, a really, really long membranous tendon, mishmash of muscle fiber directions there, and then a tendon attaching onto the tibial condyle. Okay, so that's all the information from the slides there. So you can see that coming down here and then attaching onto the tibia just there. But again, it's not as clean as the images in the book, as you can see. Okay, so there's membranosus, so a long flat membrane, and biceps femoris isn't there. So ischial tuberosity, from there onto that tibial condyle, just there. Okay. And then semitendinosus is on top. And there it is there. Okay, so we've got this, see that bit there? So they've put the knitting needle just underneath the tendon just to lift it away. So membranosus is there. You can see membranosus just underneath. And then tendinosus is here, and it's got a really long tendon. So when you did that dog poo scrape, that's what you could feel. Okay, so that tendon is popping out because it's more superficial. So it's very close to the skin. Semitendinosus is half tendon. Ischial tuberosity again. So if we have a look at the trail guide, just move me out of the way. There's the trail guide image. So ischial tuberosity there. Short little tendon there. Muscle, long tendon attaching onto the pes anserine. Okay, so that's that one. Yeah, so it's really quite thin around that area there. So ischial tuberosity. So your sit bones, and then down here, so it's a little bit lower than membranosus into that pes anserine, so the goose's foot. Okay, so Sargent group, Sartorius gracilis, semitendinosus. And then there's the attachment of the ischial tuberosity again, and then in comes biceps femoris. So just there. So you can see that like the attachment up here, if I just pause that, just hold that there again. Just wait for that biceps to come in. There it is. Okay, cool. So you can see how kind of broad the attachments are for the ischial tuberosity. So they're all kind of bunched up together in the hamstrings, and then obviously split off and go in their different directions. You can have problems here as well. So you can have tendinopathies of the hamstrings. We call it a proximal hamstring tendinopathy. Proximal means closer to the midline of the body. So that's quite common. There's also bursa around this area here, so you can irritate the bursa. And what else? Yeah, you can have a complete avulsion fracture, okay, which means that the muscle comes away from the bone. I had a patient with that once. She slipped on a wet floor in a shopping mall, and basically did the splits. And she wasn't a gymnast, wasn't really prepared to do the splits, and yeah, she was basically like, "Oh my god, I can't walk." But weirdly, didn't have very much pain. She phoned me up to see if I could see her, and I said, "Give it a couple of days and see what happens." And literally, the whole of the back of her leg turned black and blue. It was like she'd been hit by a bus, and I was like, right, you need to get an MRI. She got an emergency MRI, and she completely avulsed all of her hamstrings. So no amount of soft tissue or any other kind of intervention was going to help that. So she had a surgery to reattach the muscles. But weirdly, she still had extension. So she could still extend, and she could also still flex the knee. And it's because there are other muscles that can help out. So the adductor magnus can help out with extension of the hip. She was in quite a lot of discomfort, so couldn't really flex the knee very much anyway. But yeah, you couldn't really tell that there was a major problem. But just from the way that she described it and how it felt, I was like, yeah, I think that it's not for me to help. So sometimes you have to wait a little bit for things to happen. We've had people in clinic before where we think that there's a hamstring strain. There's no visible sign of it. You palpate it, and it's a little bit tender. But then 2 days later, the bruising comes out. And quite often, the bruising will travel down the leg as well because of gravity, and they'll get a bruised heel. So they'll get a bruised foot. Okay. So it's completely away from the injury site. And again, that's why looking at someone's posture is useful not because we want to see whether their posture is, this bit's higher than that bit or whatever, because that's a waste of time. But we want to have a look at the whole body to see whether there's any obvious signs of injury. And with injuries to the biceps or the hamstrings, it often will bleed down into the leg. Okay, so that's something to look out for. So yeah, let's have a look. Tendon looks very skinny. Yeah, I think these people are probably in their 80s. So it won't be, if you're used to dealing with fit, healthy people, then their tendons will be a bit thicker. So that's quite common in cadavers. Yeah, you think she'd be screaming. Yeah. There wasn't very much pain. But yeah, obviously loss of function. So we knew that something was wrong. But I just had a feeling that that's what she'd done. And yeah, and it was. But she's okay now. Cool. So that's that there. Yeah. So that's your long head there. That's your short head there. So you can see the where it joins between the two. So there's your ischial tuberosity attachment, long head. There's your short head attachment there. So linea aspera, and then onto that supracondylar line just there. So that's short head, and then they both then join together. So two join here. You can see that join, and then this is coming laterally, lateral. There's the kneecap. There's the patella onto that fibula head, just there. Okay. Cool. Right, let's have a look at this one as well. So this one is more focused. It's hamstrings again, but more focused at the knee. So we'll have a look at that. We'll cover the hamstrings again when we do the hip, but we'll focus on the hip end. Okay, so here's your triangle space. Yeah, so there's semimembranosus and semitendinosus. So again, that tendon just along there's the tendinosus tendon. So you can see as it wrapping around the kind of back of the knee, tendinosus on top, which is what we were saying before. You can see this video is great. It's nice and slow. Membranosus on this, biceps femoris on this side. Okay, so there's your semitendinosus with the long tendon, membranosus there. So attachment point here for membranosus, posterior medial tibial condyle, so right at the back of the tibia, and then the semitendinosus on the pes anserine, and then there's your biceps. Okay, so that's where they've both attached to each other by that point. There's the long head, and there's the short head. So linea aspera for the short head, ischial tuberosity for the long head, and then all the way down onto that fibula head just on the outside there. There it is there. Okay, so that just zooming into the back of the knee. Okay, so that's what that one looks like. Cool. Perfect. So that is all the muscles of around the knee. So we've had a look at the anterior compartment, the medial compartment, and the posterior, how they all interact with each other. And we've mentioned a few times that each compartment has its own nerve supply, blood supply, mainly nerve supply. So yeah, blood supply as well. But there are some exceptions. Okay, so we'll have a look at that. But on the whole, they're very similar. Okay, so let's just have a look at this one. So yeah, this is just another image of the compartments. So here's your anterior compartment. So sartorius, vastus medialis, vastus intermedius, vastus lateralis, rectus femoris. Okay, so all of those there is that anterior compartment. And then you've got the femoral artery and vein in there as well. And those will be the structures that innervate and supply blood to this anterior compartment. Okay, so what you'll get with the nerves, which we'll see in a second, you'll get a nerve coming out of the nerve root, which is what we call a mixed nerve. So it's a mixture of motor and sensory. So we've got some sensation coming back towards the spinal cord, and then motor impulses going towards the muscles, telling the muscles what to do. and it's a two-way traffic, but we don't know which one's which just by looking at it. You wouldn't be able to tell. You'd have to test them. But when in the thigh, what generally happens is you'll get your main motor branch, and then coming off of that, you'll have these little sensory nerves that go to the skin, or go to the joints, so that they can tell where the joints are, or if anything's happening to the skin or the blood vessels or whatever. Okay, so there are like the femoral nerve is mainly, well, is all motor in the thigh, but then there are some sensory components that go down to the leg. So we'll have a look at that in a second. This medial compartment here. So there's your adductor magnus, adductor brevis, longus, gracilis. So that's that region there. And then the one we've just looked at, the posterior, semimembranosus, semitendinosus, and biceps femoris. Okay, so again, just another image of the kind of stuff we've seen. So if you remember this will be useful. So motor branches supply muscles. Okay, so they innervate the muscles. It's not innovate, it's innervate. Okay, so sometimes people get a bit confused with that. It's not an innovation, it's an innervation. And the innervation is the motor impulse down to the muscle to create the electrical excitability to start the sliding filament theory, where your muscles contract. Okay, then we've got the sensory branches, so sensation from the skin, could be other stuff as well. And then we've got articular branches of nerve, which are sensation from the joint capsule, the ligament, synovial membrane. Yeah, so if there's any problems around that area, then the sensory nerve, the articular branches, are sensory nerves, and they will send information into your spinal cord to let you know whether your joints and your ligaments are happy. Okay, so there's various different things that do various different jobs. So let's have a look at the first one. What time is it? We'll do this one, and then we'll pick up the nerves again on the next session. So femoral nerve, or femoral nerve, whatever you want to call it. So we've got anterior and posterior divisions of the femoral nerve. Okay, so as it emerges from the nerve roots and comes out of the pelvis, it splits into two. So we've got a bit that goes forwards, so anteriorly, and a bit that goes backwards, it goes posteriorly. So anteriorly, we've got two motor and two sensory branches, so coming to the front of the thigh. So the motor branches, they supply your pectineus muscle, which we haven't had a look at yet, but that's one of your adductor muscles, and the sartorius, which we have seen. Okay, so anteriorly, in the anterior compartment, we've got sartorius, which is what we've been looking at over the last couple of weeks. And then sensation-wise, we've got two sensory nerves. So the medial cutaneous nerve, cutaneous just means skin. So medial is the midline. So we've got the midline skin nerve. Okay, so sensation for the kind of middle portion of the front of the thigh is supplied by this particular cutaneous nerve. Okay, so if you lose sensation on the front of your thigh, then there may be a problem with this nerve. Then we've got intermediate cutaneous nerve, so in between skin nerve, and again that supplies that kind of front middle area. Okay, so it's quite a broad. We'll have a look at a picture in a second. Posteriorly, we've got four motor and one sensory branch, and then two articular branches. Okay, so the motor branch are all of these. These are the ones that we've been looking at. Yeah, so in the anterior compartment, rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, and then articularis genum as well, which is again all in that anterior compartment. Sensory wise, we've got a nerve called the saphenous nerve, and we'll have a look at that in a second, but that supplies quite a large area of skin. Okay, and we'll have a look at that when we get to it. And then articular branches at the hip and the knee. Okay, so the joint capsule, the synovial membrane, the ligaments that surround the knee and that surround the hip, those are all supplied, the sensation from those regions are transported back to the nervous system by this posterior division. Okay, so it splits, but focuses on the front of the thigh. Okay, and this is quite a nice picture of everything. So we've got femoral nerve from lumbar spine, and we'll do that. We'll focus on that when we get to that region. So don't worry about that right now. Femoral nerve supplies. So if we have a look here, we've got this region here. So that bit to that bit. That's what we've been focusing on. So this is the thigh. There's your anterior division of the femoral nerve. So it's just coming over the iliac crest, around by the pubis. Sorry, not the iliac crest, that's too high. So around the pubic area is where it splits. And then we've got sartorius branch and then the cutaneous nerves to the skin of the thigh. Okay, so that's the first division. And then the posterior division is this really long one. And in the thigh, it's supplying all of these muscles. Okay, so these are all the muscles that we've just been looking at. There's a branch that goes off to the hip joint and supplies the sensation for the capsule of the hip. And then we've got, as it goes into the leg, it then turns into the saphenous nerve, which is all sensory. Okay, so there's no motor part to this. So if we think about that, so from here, in this region here, it's one nerve. But if you think about it, it's like loads of little cables within that nerve. And we've got some motor ones, some sensory ones coming back in, motor ones going down. But they're all bunched up together. And then when they get to certain points, they then go whoop, and they split off and they go off to whichever thing they need to do. Okay, so some of them just purely motor, some of them mixed still. So if you have a look here, so that area there, that will be mixed still. And then there'll be a motor branch going off to sartorius to contract sartorius. But then anything below that, there's no motor. It's all sensory. Okay, so that those will just be sensory coming back in. So it'll be sensory there, mixed. Yeah. Here will be mixed. When it gets to here, sensory all the way down. Okay, because there's nothing else below the knee that this nerve does to any muscles. It's all then sensation. If you have a look at the sensation, we've got infrapatellar, so around the knee joint. So there's another branch for the knee joint there. Skin on the medial side of the leg, skin on the medial side of the foot. And we've had a look at that when we looked at the sensation in the leg. Okay, so hopefully that makes sense. We've got mixed nerves. That looks like motor branch. Yeah, because that's going to pectineus. Motor branch to sartorius. Sensory. Okay, so that's purely motor, purely sensory. Mixed. Motor branches coming off. Mix, and then sensory all the way down. Okay, and if we have a look at the sensation for what that is supplied, that's quite a nice one. So you can see all the muscles it innervates, and then once it gets past the knee, no more muscles. It's all skin. Okay, so it's providing the sensation to the skin and the joints. And then here we go. This is what I was after. So here's your sensation. So we've got the sensory branches of that upper part that's supplying all of the front of your thigh. And then as it gets past the knee, it's then the saphenous nerve that then supplies the inside of your leg. Okay, so all that area there. Cool. Hope that makes sense. We will be going over this again, don't worry. Okay, so I just wanted to do an introduction to the nerves because we've talked about them quite a bit, starting to add those in now. Cool. Episode 150. That's just mental. Can't believe I've been doing it for that long. So hopefully that was useful and made sense with the motor, sensory, articular branches of the nerves. Like I said, we've got a bit of a break now until we come back. And Martin has just sent me a message. It's his birthday on the 29th when we're back. what a birthday present is to have I learn anatomy online at 10 o'clock on the Monday. Cool. So I hope you have a good week, and I'll see you on the 29th of January. Take care.